And I was also wondering why I have the title Women and MPN, but anyway. And the big challenge of speaking after two close friends and really excellent speakers. So thank you for the invitation to be here today. I think this is really a wonderful opportunity for MPN patients, MPN physicians, and the MPN community. And what I wanted to do in this talk was think about gender and the impact of gender on disease. Now, the obvious thing you probably think I'm going to stand and talk about, I will talk about. So I'll talk about things like contraception and pregnancy. But I also want to focus a little bit on whether actually it matters if you're a woman or a man in terms of all the things that both Carlos and Ruben have described. So we've heard very eloquent talks about the clinical features of these conditions. And effectively, we've used the word heterogeneous a lot. That means that, of course, some patients are asymptomatic and remain so for the entirety of their disease course. Some patients have the majority of their symptoms or a complication at the beginning of their disease and then not a problem afterwards. But other patients, unfortunately, have a series of complications or complications related to therapy during their disease course. Pregnancy must be included in this because this effectively, the ability to have a family is what a basic kind of human right. So these diseases can impact on that in several ways, as well as the impact on your family and on the way that you interact with them. These are features that we'll come to later. So Carlos did touch on this, but there are some age as well as gender-specific differences when we think about these diseases. And they can be important in terms of thinking about which healthcare professionals do we need to make aware about these conditions and when might patients need help in the course of their disease. So we already mentioned that these conditions generally occur in later life, so late middle age. They do occur in children, and I'm aware of a child under the age of 1 in the UK, but they're rare. So paediatricians generally don't know about these diseases, and what usually happens is an adult haematologist, such as myself or my colleagues, ends up assisting. There are some gender imbalances in terms of presentation, but these are quite marked, particularly for patients with essential thrombocythemia, where roughly 20% or 30% of patients will present before the age of 40, and many of these are women. So that begs the question of why, which we haven't really worked out scientifically, but it could be in relation to how blood cells are made and how the interaction between estrogen, one of the female sex hormones, and hemopoiesis. And that's something that we're beginning to explore in a clinical trial that I'll be talking to you about later in this meeting. But is it really true? This is a book my husband bought me when we got married. Men are from Mars and women are from Venus. Yeah, we're still debating that one. But is it really true? So, if you look at some aspects of clinical presentation, I've already touched on these. So, for the disease essential thrombocythemia, we see a slightly higher rate amongst women, particularly younger women. Myelofibrosis, as Carlos has said, there's a slight male preponderance, but that probably is not that significant. And slightly more men than women develop PV. But really the most striking thing is this issue of ET in young women. There are also other differences, and these may be relevant in terms of how we think about disease, and they may not. We haven't really worked out what they mean yet, but I thought it was interesting in the context of this title to just raise them with you. So there was a very big study thinking about the role of aspirin, an antiplatelet drug, in polycythemia vera that was carried out in Europe and that was finishing up around the time when I began as a consultant in the early 2000s. And in that study, they were studying patients with polycythemia vera and looking at the role of aspirin, but they also followed up a very large cohort of patients for a long time. And they found that women with this disease were more likely than men to have venous thrombotic events and so-called microcirculatory disturbances. So that we think that's when the platelets, for example, aggregate in the small blood vessels and cause symptoms like headaches, migraine-like phenomena, or burning and tingling in the digits known as erythromelalgia. While men are more likely to have arterial events, and this is over and above the normal distribution that we would see in the population. Something that happens more commonly in MPN patients than any other patient, actually, is something called the splanchnic vein thrombosis. We're fond of rather odd terminology in this field. Splanchnic veins are effectively abdominal veins, and including the supply to that mysterious organ that Ruben spoke about, the spleen. But this is important because these kind of thrombotic events affect the function of the liver. Some patients need to have a liver transplant as a result, and they can also affect the function of the bowel. And I was unfortunate enough to see a young patient recently whose diagnosis was missed and who went on to have a small intestine transplant. So these thrombotic events occur more often in young women. So in some series you can see, I don't need to read these figures out to you, 5 out of 6, I think it's 17 out of 19 cases were female. So this is something we need to think about. It's not all related to contraceptive use. And also another funny place that MPN patients tend to have blood clots is in the veins over the top of the head. In fact, one of the pictures on the first slide I showed you was a picture of that. So these are also important considerations. But particularly important are the topics you probably expected me to talk about: contraception, pregnancy, and management of the menopause. These are all things that are generally dealt with by other disciplines. They're not dealt with by haematologists. These are rare conditions. So usually the people who are dealing with them are not aware of the condition and may not be so worried about minor abnormalities of blood counts. So it's unusual to have this kind of situation, and also we don't know very much about it, but we can make some recommendations. And recommendations actually are very useful for the medical community, both in terms of education, but also in terms of management of practice. And there are a variety of different recommendations for the myeloproliferative disorders, and the UK has some. In America, Ruben and colleagues have just drawn up some. There are some in Spain, etc. These are the UK recommendations regarding estrogen-based therapy. So using estrogen and progesterone-containing contraceptive pill is associated with thrombosis. Therefore, we don't recommend it in young women. But occasionally patients will crop up who've had these, so it's a really important education point. Increasingly, women leave it until late in life to have families, and increasingly fertility becomes an issue, and ovarian stimulation therapy, usually for the purposes of IVF, is also problematic, and occasionally we come across these kind of cases. More commonly, we need to be thinking about hormone replacement therapy. Now, this has been incredibly controversial. It's wonderful, it's terrible, depending on which day of the week you read the newspaper. But this can be very important and needs to be thought about, and there's very little literature with regard to this. So if we can, for example, combine in a network and gather data about what happens when women with MPN have hormone replacement therapy, that could be incredibly useful. At the moment, we've got only one small piece of evidence with less than 30 women on which to base our practice. Now on to issues of pregnancy. This is an issue that comes up quite often, and we don't have very much information with regard to it. So because of the tendency to form blood clots, the placenta, which is the blood supply to the baby, effectively doesn't often work well in pregnancy. In pregnancy anyway, there is an increased risk of both bleeding and clotting, and so not surprisingly, women with MPN are more at risk of these. And there is also the risk of damage to the baby with the type of drugs that we use to treat these conditions. There's also a risk of causing infertility with some of the older drugs that were used. Also, because of all of these issues, sometimes an MPN can be diagnosed in pregnancy. So what do we know about pregnancy and these diseases? Well, for those of you who will remember the earlier slide, it won't be a surprise to you that we know most about ET in pregnancy, but we don't know heaps. We only know about around 460 pregnancies. In terms of the numbers we've been talking about so far, that might sound like a lot, but it's not actually a lot when it spans over 25 years and our practice has been very different. Broadly, we expect a successful outcome in pregnancy in between 50 to 70%. And more recently, Dr. Bessis and I have been involved in a large study across Europe called the Excel study of almost 4,000 ET patients. And we observed a roughly 70-75% success rate. So we're probably getting better at successfully managing this condition. All sorts of potential problems that can happen to women in pregnancy, and sometimes these may, as I mentioned, lead to diagnosis. It's very sad when occasionally I see a patient who had a series of miscarriages 10 years previously and then turns up because someone did a blood count and found that the platelet count was high. Probably those miscarriages were due to the underlying blood disease and probably they could have been managed. What about polycythemia vera in pregnancy? Well, we know much less about this. I had to learn about this very quickly because one of the first patients I saw as a consultant was a lady who'd had 3 big miscarriages or stillbirths with PV in pregnancy. Happily, she's actually one of the cases that we wrote up in this report. She was managed successfully, and pretty much we think this condition, we can manage it in the same way, and the success rate is likely to be about the same. So guess how much we know about myelofibrosis in pregnancy? Not a lot. But it is becoming more of an issue and more of a problem because we do diagnose these conditions earlier, and often patients who've got early stage myelofibrosis may well have 20 or more years to live. It's very heterogeneous, and this becomes an issue. So can we predict complications? The bottom line is maybe, but probably not very well. Usually the blood counts will change in pregnancy, but it doesn't necessarily predict outcome. If you've had a disease complication, that might mean that your pregnancy is more difficult to manage, but not necessarily that it won't be successful. If you've had problems in pregnancy before, it may mean that you have problems again. And there are all sorts of things that we test for in women that have had miscarriages or pregnancy problems that we might think are sensible to test for in this condition, such as, is my blood exceptionally sticky? That's the interpretation of thrombophilia, by the way. But they don't necessarily help in this setting. What about JAK2? Carlos showed that beautiful slide of the 2 faces, not just of Janus, but 2 faces, CALR and JAK2. Actually, maybe having JAK2 means that your pregnancy is less likely to be successful, but there's not a big impact. We can monitor blood flow in the placenta, and that's probably one of the best ways of actually monitoring successful outcome in pregnancy, and this is something that we advise. And this is actually something that we've learned from other conditions. We think probably that patients with calreticulin have got mutations have a better outcome in pregnancy, but there are very few series of patients on which to base that on. So, this is a really common question that I get asked by email by colleagues all of the time. There is a structured approach to managing pregnancy, and there are available publications and, as I mentioned, guidelines. And on the whole, there needs to be a partnership approach. So we need to work hard to educate our colleagues in obstetrics and gynecology and neonatology. We tend to meet with our patients and make plans for management. There are drugs we can use in pregnancy if we need to. There are ways of identifying higher risk pregnancies. Many of them won't be a surprise to you. Patients with blood clots, patients with diabetes, patients who've had previous complicated pregnancies. Generally, women in pregnancy need to attend the hospital a little bit more often if they have one of these conditions, but not that much more often, and they can be managed in their local hospital, provided things haven't been too complicated in the past. Generally, we allow them to labour normally and we allow them to breastfeed, but we like to monitor their blood counts after pregnancy because then is the time when blood actually becomes naturally more sticky and blood clots tend to happen. Occasionally, things don't go well and we have to manage our patients through pregnancy in a different way. These little girls are, I think they're 6 now. They thunder around the clinic sometimes. Their mother, unfortunately, had a very big stroke at the beginning of pregnancy, and she is an inspiration to me, as are many of my patients. She is a young woman who went through 3 different treatments, 5 different pregnancies. The last pregnancy she tried to have ended up with her having a rather massive stroke, from which she's made an excellent recovery. And now she's the mother of these 2 lovely children who arrived finally after a surrogate pregnancy. So I want to end here with a few minutes to spare with the view almost from St Thomas's, and to make another observation about women and MPN. In healthcare, increasingly, especially in the UK, many doctors are female. In my team, I only have 1 male doctor, but I have plenty of excellent male colleagues. Especially the role of the nurse. So Yvonne Francis is one of our nurses. She's going to come to the meeting later. And I think this is another thing to be thinking about and to touch on the theme of women in MPN. And I'd like to leave that up as my last slide. Thank you very much.